We now move to the next talk, which is Improving Patch Testing Technology, Future Strategies. And the speaker is Dr. Syed Mubhashir. Our chairpersons are Dr. Atul Vijay and Dr. B.C. Ghiya. Dr. Atul Vijay is Professor and Head, Department of Skin and VD, Jhalawar Medical College. Dr. B.C. Ghiya is Professor and Head, Department of Dermatology, SP Medical College and PBM Group of Hospitals, Bikaner. He has been in 20 years for UG teaching and in PG teaching for 15 years. He is a life member of IADVL, Indian Association of Study of Sexually Transmitted Diseases, Cosmetology Society of India, and Association of Cutaneous Surgeons of India, and has multiple presentations and publications, national as well as international. We welcome you, sir, and we request you to chair this session and introduce us to the speaker.
Oh, good evening.
Good evening, sir.
Good evening. I invite Dr. Syed to present his presentation. Dr. Syed Mubhashir, please start your session.
Very good evening to everybody. Are you able to share, see my screen?
No.
Hello? But I'm sharing this, sir. It's not coming. It's not visible.
Syed,
Yes, sir.
it's not coming.
Started, sir?
It's coming.
Okay, at the outset, I'm highly thankful to the chairpersons for giving me the kind introduction. And before I start, I'm highly thankful to the team, Codfi, especially to Dinesh Mathur, sir, for giving this opportunity. My talk is on improving patch testing technology for the future strategies. As far as this is concerned, we should be in a position to identify the allergens. There should be availability of the antigens, proper training, specialist contact dermatitis clinics should be there. Upgradation of already established contact dermatitis clinics along with the staff, proper training and fellowship programs for the dermatologists should be there. So as far as patch testing is concerned, is an essential and well-established method of diagnosing contact allergy, wherein the patients with a history and clinical picture of contact dermatitis are re-exposed to the suspected allergens under controlled conditions to verify the conditions. We all know this. So the focus of this talk will be on the further future strategies and directions like improved patch testing technology, patch testing strategy, and patch testing clinical relevance in allergic contact dermatitis diagnosis and the management. So as I already told, the identification of allergens, availability, infrastructure, staff, upgradation, and training is very much important. So proper knowledge, identification of local and indigenous allergen is very important. Standardization of the skin test procedures and standard panels for different geographical locations are encouraged, should be encouraged worldwide to permit better comparison for diagnostic, clinical, and research purposes. As far as stability is concerned, this is disconcerting because we may be able applying commercial antigens without knowing how long they are biologically active. This information deserves to be open source either on the allergen package insert or on the internet. Another thing, as far as identifying the true allergen, knowledge of allergen structure, processing, and recognition by the body may allow structural modification of common allergens to allow their use without inducing allergic reactions. So when patch testing with PPD yields a positive results in the, is the patient really allergic to PPD? Or is the patient allergic to metabolites or gradient produced on skin after contaminated contact with PPD? These things we should consider before giving it a true allergen name. As far as irritancy is concerned, future patch test design should aim to identify methods of demonstrating allergenicity without false positive due to irritation. Advances in dermatopharmacokinetics must be useful, for example, as in case of formaldehyde or lanolin. So as far as patch wearing periods is concerned, Patients would appreciate a shorter wearing patch timing. It requires further investigation and discussions, yet international standards remain the same. So we should explore this thing, and we should come up with those things where the patch wearing period should be less. So as far as application is concerned, evidence in animals and humans suggests that chemicals may need not only 30 minutes of application for percutaneous penetration. This would result in increased convenience for patient because patch worn on the back for 48 hours can be inconvenient and uncomfortable. Increased test concentration might permit such an advance. So patch testing banks. These banks could distribute uncommon allergens to dermatologists for a flat annual fee and could also record response data to determine the frequency of sensitivity to rare or new allergens, thus serving as an early warning system. As far as false negative patch test results are concerned, too, uh, too low a concentration or to an inappropriate vehicle or compound allergen. When the product is highly suspected, a repeated open application test or a use test is applicable. Testing of micromolecules may be obviously difficult because of low penetration throughout the skin. Retesting after swapping with alcohol or after stripping of stratum corneum or an abraded skin crash patch test is sometimes used. As far as false positive reactions is concerned, false positive reactions can result from a hapten tested at irritant concentration or a mechanical pressure. A resultant classified as positive query or positive should be retested. A weak patch test reaction to a substance that is strongly suspected to be the cause of allergic contact dermatitis occurs. It is preferably to perform in addition to and after patch test a repeated open application test. So what are the enhanced material safety data? So in improved material safety data sheets, legislation should be targeted. The issue of secrecy regarding the ingredients of pharmaceutical, cosmetic, and consumer product should be addressed. Currently, if an allergen is less than 1% of a product, it does not need to be listed. Correcting this on global scale will aid the patient. That will be very helpful as far as allergic contact dermatitis and treatment is concerned. We need a clear view of chemical mechanism of allergens and whether the true culprit is allergen itself, a cross contaminant, or a skin metabolite, if we go according to this thing. So as far as commercial availability of serial dilution is concerned, testing of with serial dilution permits determination of just how the allergic patients are. Not everyone reacts to the same concentration of substance. Some may react only to a higher concentration, thus allowing some exposure without phenotyping signs and symptoms. Clinically, immunology should not be considered an all or none science, and there are large inter-individual variations in the amount of substance needed to elicit dermatitis. That should be also taken into the consideration. As far as testing on dark skin is concerned, skin in patients with dark skin is importantly clear. Identifying the test site can be done either by solution using silver nitrate, gentian violet, or fluorescent skin markers, and subsequently reading it with wood lamp in a dark room. And as far as my last talk is concerned, as far as patch testing in children is concerned, it's more difficult to distinguish between an irritant and a weak positive reaction, probably due to lower irritancy threshold. And increase in excited skin syndrome occurrence has been emphasized in children. So no difference are needed regarding the technique of patch testing, duration of skin exposure, time for interpretation and grading of positive reactions. These are as far as same as far as adults. But due to limitation of test area, it is preferable to utilize small aluminum chambers or hypoallergic tape. Irritant reactions may occur when aqueous solutions or mercurial like are tested by aluminum chambers due to corrosion of chambers. In these cases, plastic or cellulose chambers must be used, and aluminum chambers may be safely used in test mercurial dispersed in petrol litter. Thanks a lot. Thanks for listening. Thank you, sir.
Thank you, Dr. Syed, for nice presentation.
Thanks a lot, sir.
Thank you, sir.
Thank you.
Thank you for a wonderful presentation. I also thank our chairpersons for chairing this session.